conversations and learn a thing or two. And I don't burn nothing in my kitchen.
This is Miriam, and you're listening to KXVS, the voice of Stockton.
You know what I got? I got a picture of his face with the little pillow on, with the sleep face, and we're in Chicago.
Are they already in Chicago? The one and only Leo Biaz. Hey, Leo.
I'm excited to be back, my man. It was 9 days in Vegas. We got stuck in the desert, and we had a little hangover remix out there, man.
I wore a wig to school once, and they said no headgear was allowed.
How did
spider web
was it
tights.
Obvious that it was a wig?
Yeah.
Oh, okay.
I was having
a terrible
fun.
wig.
See, this is exactly why we have them on the show, and this is what makes them fun.
You're listening to KXVS, the voice of Stockton, 92.1 FM.
Do you want to relive the golden days of Stockton? Join Nate Knott on Stockton Alive every first and third Monday at 6 p.m. Tune into thevoiceofstockton.org.
This is Darius Oliver, and you're listening to 92.1 KXVS, the voice of Stockton.
The views and opinions expressed in the following program do not necessarily reflect those of KXVS, the voice of Stockton, or its parents, affiliates, management, and staff.
KXVS, the voice of Stockton, presents Connections, Peace and Justice Radio, with your host, Bruce Giudici.
Good evening. Bruce Giudici. I'm the editor of Connections and host of this show on 8 to 9 every Monday evening. And this evening we're going to talk about what's going on with single payer and what the news is with Kathy Mathis and Max Heinemann, local experts on the process of getting to a single payer or a Medicare for all system, however we get to what we need to get to. And so this evening, we just wanted to sort of cover the latest developments as to what's happening with the SB 562 bill that's probably is expiring, going in. Well, it expires every 2 years, right? So,
at the end of this month.
At the end of this month, which is July, right?
That's right.
Yeah.
And
so what's happening, Max?
Senate Speaker Rendon has had his feet both on it. Won't let it out of. Off the shelf.
Still, that's been all year.
Yeah, and so it's going to die in a couple of weeks.
And so this
what we need a champion in the California legislature to either reintroduce a bill in the Senate or in the Assembly. And
so this is an election year. It's a time for us to talk to our representatives, and this is at the state level. Mm-hmm. So this would be Susan Eggman in the Assembly. Is that correct? And then in the state Senate is who's our state senator?
Kathleen Galgiani.
Kathleen Galgiani. And so these two women are should be hearing from us. I don't know to what extent they support a single payer.
They may be waiting till after the midterms and see if Gavin Newsom gets in. And if he does, what his signals will be.
Well, he signaled during going into the primary that he was going to back single payer. I thought he was pretty strong on that. In fact, I think that was sort of a signature.
We've heard that before.
Yes, we have. Yeah.
Not to be cynical.
Yeah, right. Well, the thing is that politicians don't really lead. You know, politicians follow
the takeaway.
Yeah, they'll follow what is popular. And so what is important for us to do as citizens is to make certain that they hear our voice and that they understand that this is a signature important life and death issue for just about all of us.
We need to build a movement.
Yeah. And the thing is that a lot of people who would have thought that, single payer, Medicare for all, however we get to a non-private insurance-based system, 4 years, 5 years ago, if we were mentioning single payer or Medicare for all, people would say, oh, that's just so idealistic. There's just no way we can get there. We have Obamacare.
Or they would say, what is that?
Yeah, right. That was the usual
What are you talking
thing.
about?
More likely, single payer. Who do I pay?
Yeah, exactly.
Do I just pay my doctor and that's it? And so, but I think what article I'm running in Connections this time, and what I've been running in most Connections, is talking about how single payer and Medicare for all is becoming people can envision it. People can see that it's something that we could live with.
And well, it saves money.
Yeah. And
not only can we live with it and have really good health care, it saves about 18% of what we now spend of our GDP.
Yeah.
And so
well,
that's the amazing thing.
A lot of people are familiar with the concept. You know,
Right.
they know somebody who has Medicare, or they're waiting to get Medicare themselves.
Right.
And so why not make it so everybody has one of those cards, and that the card covers everything.
Yeah. Yeah, because, I don't mean to get all economic about it or anything. But,
oh, please.
But really, when markets fail, that's when, you have systems like regulated monopolies, or you have governments entering into the marketplace to ensure that the markets run well. And so, like, say, when the stock market crashes and loses 1,000 points in an hour or something, the government comes in and says, okay, we're going to stop trading for a period of time until things mellow out. Or if there were price spike, like you look at the 2008 financial crisis, when the stocks were going down and people's equity was disappearing, you had to have major governmental market intervention to stop that from happening, and to intervene, and financial legislation like Dodd-Frank was introduced to keep that from happening again. Now, of course, the people who are the for-profit people are trying to undermine that very law, but still, when markets are failing, like you see right now, you see rural hospitals just going under because they can't afford to pay their bills. There's got to be some sort of way to ensure that a rural community is able to,
well, and a single payer
allow a baby to be born in their hospital.
Yeah, a single payer program would do that. You wouldn't have people who can't afford health care going to your hospital and then stiffing you for the charge.
Right.
And so the county hospitals and the small community hospitals would get paid for the service they provide.
That's right. Yeah, because right now the hospitals are just not able to pay the bills, pay to get a doctor or a medical staff to come out to a town like Markleyville, or a town like San Andreas or Angels Camp, or wherever the tiny town might be, because they just can't afford to attract a doctor to come. And so, or a nursing unit, or a prenatal unit, or a trauma care unit. And these are the sorts of things that you expect a well-developed economy, the richest country in the world, to be able to provide for their people. It's sort of basic services, and the fact that we can't provide basic services means we really have to rethink the model.
Well, it wasn't too many years ago that our county hospital here. It was a question of, was there going to be a change, or were we going to sell it, or ask someone to take it over?
Right.
That was, a serious consideration, because they were losing millions of dollars a week.
Yeah.
And it was, we're going to sell it or give it to someone to stop the loss. And fortunately, Obamacare came along, and so that was a temporary saving. And I guess I haven't heard anything recently about selling it.
Yeah. Well, people, think of Obamacare as being such an abomination, but what it was is just patching the holes in a for-profit system, where you're just tax some of the services in order to provide like say either the medical devices, or you're going to tax a higher income group or whatever, and transfer those funds so that you can actually have some services for low income communities, and you can subsidize their
we subsidize poor people's premium to buy insurance,
right?
And who pays for that is the general population,
right? And then again, what you're doing is you're paying people to pay into a system that is very inefficient, and you're essentially throwing money away. I mean, it does cover people, which is a benefit, which is a good thing.
County hospital's still here,
but at the cost of still wasting funds that could be used to serve more people.
Well, yeah, there are a lot of people who were left without any health care coverage at all, and then the underinsurance problem is huge. And to me, one of the big flaws in Obamacare is they did expand Medicaid, which I think is a good thing, but then there are a lot of people who are working poor who don't qualify for Medicaid because they have too high an income, but they have the kind of income that doesn't really allow them to pay premiums out of pocket, and their employers intentionally keep their hours under 40 so they don't have to provide insurance. And so those people, what I think it couldn't have been designed better to do is pit the working poor against the very poor.
Yeah.
And instead of looking at the upper classes to say tax heavily.
Well, I wonder who set up the system that we have now. The whole Obamacare system was designed by insurance companies so they could continue their business. I mean, the whole idea was to, that was the most important thing, was to maintain insurance companies' ability to continue to function.
Yeah, so now we have insurance company middlemen who preempt the clinical judgment and make decisions about reviewing whether you're approved for a certain procedure or not, or denying the payment for a procedure. So their number one objective is profits.
And also either to deny care or to find the cheapest possible alternative. Right. And when you're looking, and so when these insurance companies are looking at the formulary or looking at the list of pharmaceuticals that they can offer, they're looking at a list of prices there that are set up by another for-profit company who is extracting massive amounts of profit over what those choices are. And so what these folks are doing is trying to pick the lesser of 15 evils, and 5 of those evils have been advertised to you every single night on the nightly news, that you should be asking your doctor about this and this and this, and say, when was the last time I was going to get ovarian cancer or whatever. Some of the ailments that they advertise that they want you to take medication for is like so obscure. I just can't imagine.
Well, either that or, fairly common. I mean, who doesn't have some social anxiety here and there, Do we all need to be on Paxil? I'm not really sure.
Well, maybe we do. Although cannabis would be much cheaper, I'm sure. Ask somebody from Calaveras County. But really,
Paxil's pretty cheap. It's one of the cheaper ones.
Is it? Well, yeah. I have to say I've never seen an advertisement for Paxil because it probably is so cheap. It's like a advertisement for amoxicillin or something.
Yeah. Well, I'm hearkening back to when advertising first came out, and I think I was in medical school, and that was a comment the particular attending I was working with had at the time.
Yeah, because advertising for drugs wasn't always legal.
No.
Right. There was a time when that was
most of us can remember when it wasn't legal.
That's right. Yeah.
Most of us can.
Yeah, that's right.
I think it's about 20 years now. I think it was the late 90s that advertising came about.
And now I think it's termed under their research and development line for their when they're talking about program costs, because under Obamacare you're not supposed to have more than 15% of administrative cost going into your provision of care for the insurance companies. And so what you can do is you just
shuffle the cards.
Some way
recharacterize those expenses as being research and development.
Yeah, I'm not sure how those limits get interpreted when we have CEOs they're supposed to be limited to $1 million annual income, right? And
somehow fudging that one.
Yeah, they end
maybe
up
stock options don't count under that tab.
Well, apparently not, and they end up with $20-30 million annual income.
Aren't they still in the hundreds of millions of bonuses? I don't know.
I don't know.
They used to be. I doubt that's
something
changed
adds up.
much.
Something has to go in there to add up to a $30 million annual for some of the CEOs of the.
I just can't even imagine $1 million a year.
I thought they were getting like $200 million. Some of them.
Well, this is Peace and Justice Connections. I'm Bruce Giudici. I'm here with Max Heinemann and Kathy Mathis. We're discussing single-payer healthcare and Medicare for All. And I've been holding my sign on the corner of Highway 49 and 4 for the last 2 years since Trump ascended to the presidency, and it says "Stand for Workers, Medicare for All." And I get positive thumbs up in a fairly conservative area quite often. And a lot of people do resonate, because really the concept is that we are standing for workers. We're not standing for anybody but that, because the folks who are going to benefit from a Medicare for All or single payer system would be people who end up having to pay these exorbitant premiums.
Right.
Yeah.
And we probably will not get a SB Senate Bill 562. However, if it's reintroduced again, they can name it the same.
And that is a single payer system. So So again, what is the difference between a single payer system and a Medicare for All system?
Not much.
Okay.
The kind of the attraction for the Medicare for All is nationally that has its framework already set up.
Okay, because there's already a system where money goes into a Medicare fund. There's already a list of prices that doctors can charge for Medicare services. They get reimbursed.
The billing setup is well known in the doctors and hospitals.
The admin cost is very low. I would guess that the paperwork is standard, and so you don't have to worry about filling out a Blue Cross form as opposed to a Kaiser form or
And there'll be one form and one approval,
and that would be a nationwide. And
that's what's so critical about this. Once you're going to hear, as the election gets closer, code words like universal health care or everyone should be covered, health care for all. But if you wait, or if you dig deeper or force that candidate to elaborate, chances are very good that there's going to still they're going to advocate for the continuation of a multi-payer system. And as long as you have a multi-payer system, you're going to have big administrative departments to say yes or no at the point of service to certain people. And you're probably also going to have copays and deductibles and formularies, and it's all of this scrutiny all the time costs a lot of money, because every decision has to be run by several different layers of people who say yes or no.
Yeah, like it's a lot more efficient to go through a single payer and to have the same formulary. Everything's on the formulary. Every doctor's on the list. Every pharmacy is on the list. Everybody is available.
Right.
All hands on deck.
The way it was set up for SB 562, and we don't know that that's what will happen, but everybody in the state of every provider in the state of California who had a license was eligible to bill. Now they're going to have to have a list of those. You're going to have to be able to tell them what your license number is, and so on. But the competition will be among the providers, not among the insurance companies. There won't be any insurance companies.
Right.
So the competition, they're all going to be paid the same. So the competition will be to provide a better service, to be more convenient, to be more accessible. And that's where that's the capitalism part of it. You're going to compete with peers to see who can provide the best service.
Right. And I'm not really all that convinced that that the competition is necessary in every market. In terms of healthcare, I don't necessarily want to see a bunch of ads from UC Davis on UC Davis Med Center as to how much more efficient their birthing area is as opposed to a Stockton one, or as opposed to the San Francisco one, and that there's a ton of money put in to try to advertise to get people to come to your location because of what slick advertising campaign they're able to put together. I would like to see some sort of cap on advertising so that it's like I don't see advertising for how our fire department is better than Lodi's fire department, and how there shouldn't be competition. There should be cooperation.
Well, and it should be, like you said, a service that's provided to the community based on the community's needs.
Right.
What we have now, speaking to that advertising and the need to draw customers or patients to a particular medical center is hospitals tend to go out and buy very expensive imaging machines, and then they have to utilize those machines. Or they buy robotics for their operating rooms, or they set up cancer treatment centers. And so you'll have, 2 or 3 hospitals within the same small city, like we have here in Stockton, that have robotic, operating room equipment. And, every day that stuff sits idle, they're making payments on those. They'd like to see a return on their investment. Right. They'd like to be billing against those things. So they want to push their surgeons to do the robotic style of surgery because the compensation is better. Now, that all would be negotiated. The price of any given procedure would be negotiated with Medicare, but also presumably, this is how they do it in the Canadian format, the hospitals get a global budget, and that's determined based on the population and the needs of the area. So you won't have multiple, repetition of services.
Right.
A million years ago, I had a practice in Michigan, and I was a member of a committee which evaluated new requests from community hospitals. There, in the rural areas, almost all of the hospitals are community hospitals, like our county hospital. There are no private.
So they're public hospitals.
They're publicly
hospitals. Funded.
Yeah, and so they get reviewed for. Are they going to be is a new service that they're anticipating? Is that necessary? And of course, I was on the committee to determine mental health facilities. And of course, what we looked at back then was, did they have a means test, a way to reduce fees for certain people? That was part of what we expected them to do. But, yeah.
I thought you were going to talk about long inpatient stays and electric shock therapy.
Oh, no. This is California. So
this is in Michigan.
In Michigan, yeah.
Many years ago.
Yeah.
Not that there's a problem with electric shock.
Oh, they did electric shock there years ago. Yeah.
I don't think it's a big, money maker. Though.
Oh, I don't know about that.
I do know it's like the only procedure in psychiatry, or it was for a long time. One of the few that they had.
Who's that?
In psychiatry.
Okay.
Psychiatrists don't do a lot of procedures. That's one of the few that they do. I don't know if they do any others, but so when it went out of vogue, it was kind of like, oh no, they took our only procedure away.
Yeah.
So there's no one in San Joaquin County that does a ECT. There's a kind of a clinic in Sacramento That I think that's their primary service.
Yeah, and that's when I don't mean to equate veterinary care with human care, but they use the same antibiotics, and they're a fraction of the price, small fraction of the price. But in any case, I remember when my wife and I we had a veterinary clinic, and it was not uncalled for that we would refer things that our clinic couldn't handle. We refer them out to a specialist, and I don't see why that every hospital here has to have a machine that has to do it in store, when you can just send somebody, especially if it's a test or some sort of, it doesn't require a procedure, but if it's a testing type of thing, like an MRI or a CAT scan or something, that you can't just refer them to the one CAT scan machine that exists in the county that's probably is underused already.
Well, and those machines could run 24 hours a day, conceivably.
Yeah, So the thing is that I think a lot of times, because money is no object, those machines get purchased because the hospitals know that they can amortize them by charging a ton of money for every test to try to maybe get the cost buyback within a couple years, and then the medical device company will come in and say, "Oh, we've got a new one. This one prints in color, or this one prints in 3D," or and they'll turn it around and say, "Not only that, we'll just lease it to you." So it's sort of like what happens with copy machines. I don't know if you have any experience with how copy machines are sold or how they're leased, but I'm sure it's the same runaround, or when you buy a car, the same runaround that you get that. And imagine if you had a limitless budget where you could spend money on these devices, and there was no downside except that when you gave a tour of your hospital, you could point to that machine that goes beep and say, "Look at that! That's the machine that goes beep. That cost us $5 million."
Well, the downside is then you have to go out and find customers or find patients.
Yeah.
So.
And the thing is if you have 4 or 5 of them in the county, and really the demand is not there, then what you're trying to do is you're trying to scare up, demand, create demand for, and that's not good,
Right.
Because that's wasteful.
I think there was a big scandal up in, I think it was Reading. They were doing all kinds of cardiac stuff.
Extra tests that weren't needed.
They just had a huge, way beyond the median rate of these particular procedures, because they had a couple of specialists who made a lot of money that way, and I guess they had lifestyles to support.
Well, the thing is also, and I don't mean to put a knock on doctors, but what doctors will say is that malpractice insurance is so expensive now, that we have to really overtest to make certain that that we are covering every single base, because if we don't test for every single possible thing on that list, and it turns out that one of those things on that list we didn't test for, we're going to get sued.
Well,
and so then that ends up adding to the cost as well.
There are 2 points to what you just brought up that I think get used against single payers, so I think it'd be nice to debunk them right now. One is that issue of if we have a single payer system, the provider may not be able to order everything they want to order. They'll have Big Brother breathing down their neck, and somebody with ovarian cancer might slip through the cracks. I think the fallacy to that is they slip through the cracks in the current system, like a lot.
And it costs a lot more.
Especially because a lot of people don't go in at all because they can't afford it.
Right.
And then the flip side to that was, I had a good one.
It's okay, it'll come back. Where doctors overtest or malpractice insurance?
The malpractice insurance thing. Yeah, I mean that's an argument that tends to come from one side of the political spectrum a lot. Like really, the whole issue with exorbitant costs of medical care is that malpractice insurance. If we just got rid of tort
reform, right?
If we just had tort reform and got rid of lawsuits. Frivolous lawsuits for things like having the wrong leg amputated or whatever, and that pain and suffering compensation, then doctors wouldn't need so much money. You wouldn't have to pay so much through Medicare to get the get the fee that they deserve for whatever service they provide. But if you had a single payer system, a whole lot of that compensation, which is not for pain and suffering, but is for actual care to ameliorate the damage that was done, that's already taken care of. Yeah. And similarly to workers' compensation. I mean, there won't be any workers' compensation insurance, and so employers.
There will be, but it won't have to be as exorbitant as it is now, because it won't cover the injury. It will cover time off of work, which is easy.
Yeah, I'm talking the medical aspect of it. Yeah, I mean the medical care. A lot of times when you have a legal dispute to take care of somebody who's been injured physically, a big portion of that settlement is for their medical care. Right. But if that's just put into, a global budget
single payer.
Yeah, and it's kind of factored in, we know approximately how many car crashes there'll be, or, whatever. There are actuaries who know this stuff. Right. If you have a population of 300 million people, you can pretty much figure out how much it's going to cost to insure everybody.
Right, right.
And you really do know that. The bean counting that goes on right now is just, different insurers trying to carve out the healthiest people who can pay the highest premiums.
To cherry pick the ones that are least likely to be using the service, and they want to get rid of, shuck off the ones who are older or who have pre-existing conditions and that sort of thing. That's the big scream now about pre-existing conditions.
Yeah,
they're
trying
to bring that back. I mean, they're little by little, this Obamacare is being chipped. They're trying to chip away at it. Yeah. This is Bruce Giudici with Kathy Mathis and Max Heinemann. We're talking about single-payer health and Medicare for all. And so anyway, I wanted to give a personal story, unless you have something that's
Go ahead.
Yeah. So that it happened. It was my mother. It's how my mother died, and it sort of drags in the malpractice part of it, because our understanding was that in California that you cannot sue for more than $500,000 of medical damages or punitive damages.
Yeah,
and
it was a bill called
pain and suffering.
I think it was called MICRA.
Yeah.
But you can sue to cover the expense.
Yeah. Well, yeah. But the thing is that my mother died, and the thing is that we didn't really want. I mean, the expense wasn't. Our concern was to keep this from happening to somebody else, because what had happened was that my mom was a nurse, and she realized that her health was declining and that she was getting weaker and weaker. And there was a delay in terms of, we're going to take a test and then we'll come back in 2 months, a test, come back in 2 months. And by the time she was in the hospital, it was, she was just so weak, and they still hadn't figured out that it was, I think it was the gallbladder, or it was a bladder problem, or anyway, or kidney problem. In any case, they did an exploratory. They punctured her intestine. Oh. There was major infection. And she died a month later in ICU over at UC San Francisco. Oh my gosh! And so, that at a cost of like $300,000. I think it was $300,000, $400,000. And when we wanted to go and talk to a lawyer and say, you should not be delaying care on somebody like this, because she knew what was happening to her, and she knew that this was, that this care was being delayed, and by the time that she was, in the hospital and they were doing exploratory, still trying to figure this out, no lawyer would take the case, because they said there was not enough money to get out of this case for them to be able to prosecute it. Mm. And so when people talk about how malpractice insurance is the thing that's going to keep them from that they have to get rid of they have to have tort reform because malpractice insurance fees are so high. In California, that's not really the case, because there is a cap in terms of how much, and pain and suffering. I mean, $500,000 was something just to tell the insurance companies, don't do this again. But that wasn't even an option. That was because the thing is no lawyer would take the case. And so the hope would be is that you wouldn't have overworked doctors putting off tests, and that you would have more doctors being able to actually adequately so many clinic visits into a single day that they're not able to provide the sort of medical care that they were trained to do. And that I would advocate that I'm thinking that if we have a Medicare for all or single payer system, hopefully we'll have more mid-levels and more family nurse practitioners or physician assistants and more physicians graduated out, so that there will be more time on a appointment by appointment basis.
It is true, though, that the liability insurance for doctors in California is less than in some other states.
Yeah.
And that was a law, I guess, that passed 10 years, 15 years
I'm
ago
looking.
or something.
Actually, it passed in 1975 and was signed into law by Governor Jerry Brown.
Oh, so
back in the day,
sort of around the time of Prop 13, which was like
a little bit.
1978.
It was a couple of years before that.
Yeah, getting the government off the back.
I think it caps. I think it caps pain and suffering settlements.
Yeah,
Kathy probably won't believe that the liability insurance is less here than it is.
No, I do, because I trained in West Virginia. I had the one other student who graduated the year I did was going down to Florida, and he had a much bigger issue he was facing. There was a lot of, "Ooh, she's going to California, lucky her," and it wasn't the weather that they were talking about. It was that
low insurance premiums.
Yeah.
I mean, maybe back in 1970, but anyway, so that experience really soured me on our existing healthcare system, because it just seemed that it was that my mom died because of the profit motive.
Oh, I'm so sorry.
Yeah, that's I'm sure. I mean, I'm not alone. I'm sure everybody who's listening to this recording here has an experience or a similar experience of somebody who's been shuffled around in the medical system, has had tests that have been delayed, or have had that the system has not served them well, even though it's the most expensive system on earth.
Yeah, well, in the past few months, we've been hearing a lot about how U.S. Maternal mortality is so much higher than around the world. And I was reading this one article about, they always start out with a case example. And this, this one woman was somewhere in Louisiana, and she was, far along in her pregnancy, and she was having elevated blood pressures and headaches, and her doctor kept patting her on the head and saying, just go lie down and put your feet up or whatever. I'm like, oh my God, that's malpractice. Like, how's this guy a doctor, But, sometimes when I read stories like that, I think, well, that's really odd. I remember reading another one about a woman who had cervical cancer, and she kept going back to the same doctor, and that's really hard. It's not difficult to diagnose. So
the indicators are that U.S. healthcare is headed towards the third world quality.
Oh,
yeah. Well, the system does not allow quality care. The system is it's like a Walmart system. You try to get as much profit out of the product you're selling. I mean, and everybody is pushed into the system. I mean, the way the parameters of the system sort of force you into this model of saying, well, I'm going to try to maximize the amount of income I can get out of this product, which happens to be a client. And that's what, or a patient, and that's what the insurance companies do. They just look at people as if they're just, a banana to be sold, or a widget to be repaired.
And we pay twice as much as any other Western country for health care.
Yeah,
and we get much worse outcome.
Well, the thing about that argument is there are some people who get excellent health care, and then there are a lot who get, less than average, and then there are a whole bunch of people who get none. It's very unequally distributed.
But when you look at the total, those are totals. Our total is twice as expensive, and our outcome total, countrywide, is less than any of those other countries.
No, I understand. I understand.
It doesn't matter that somebody gets good health care.
Well, I think it does
Unless
matter because frequently those people are the ones, who vote.
Yeah.
Those are the people who help drive policy. So, yeah, as long as the policymakers and the high-end voters, especially the donor class, are getting very good health care, there's going to be no incentive from those
Probably
folks
isn't as good as they would like
change.
to think it is. But
well, maybe not.
But
what does anybody know, really, if it's not their field? Like, except, is the place clean, and does the nurses seem nice, and does the doctor come around frequently?
Well, what we find out is that people die. I mean, the more people die under this system than they do under any other system. And so the thing is, it's the same argument when you take a look at, let's look at the average income of the country or the median income of the country. And so when you look at the average, what you end up having is you have these huge incomes that skew the average to the top.
Yeah.
And so if you look at, on average our care is this is how much money we pay per person. Really, it's there's a lot of it's important to look at the distribution as to how much is being paid on for different classes or different groups of people. Because like you say, there's like a 25% group of people who are standing in line at Sioux Salute or something just to get a dental visit, or to get just to get a blood pressure taken or something like that, because they can't afford to go and see a doctor. And that's like third world type of reality.
Yeah, we have one of those dental clinics coming to Modesto in October,
and it's going to be a long line.
It will. It will.
And dental care just really gets short shrift.
It really does.
It's really important.
I highly recommend the book called Teeth that came out this year. I forget the subtitle and I forget the name of the author, but it came out this year. It's all about the class disparity that shows up in dental care. In this country. I do want to address one more thing, though, that you were mentioning, because I think, should the day come when we actually can decide what kind of single-payer system we would like, I personally like the idea of something like the National Health Service that they have in Britain, where all doctors are part of the service. All clinics are owned by the government, and they're set up, almost by a central plan. I mean, and I know, we try not to we try to decentralize things a little bit, but if you look at it like, say, the Postal Service, where you want to make sure you have care in places that truly can't afford it, if they had to bill fee for service to support a practitioner, to support a small hospital. I think those places ought to have a small hospital and a practitioner. Right. And so
even if that particular clinic would lose money.
Yeah, if it were billing by the service, but I would like a global budget to decide where places need to be, and so the care is distributed that way. I would like to see absolutely more doctors trained. Currently, the training system in the U.S. is funded through the Medicare program, and they haven't expanded that in 20 years. Wow. Because it's cheaper to import doctors from elsewhere.
Now it is,
that's a policy decision that's been made.
Which both it extracts doctors from countries where they're needed probably just as much, if not more, than here.
I know.
And they've spent the money to educate them.
Right.
Yeah.
Right. Yeah. So in terms of now that sort of socialized medicine that they have in Britain is something that a lot of people are afraid of. They say, "Oh God, we don't want to have socialized medicine." But the thing is, we have socialized military. I mean, we have a standard military that covers that provides the security for our 50 states, and we have bases in pretty much every state. And we don't really worry too much about how much it costs or whether that Air Force base is losing money. What we're seeing is that
I'm not sure we ought to look at the military.
Well, but the thing is, the military is probably, well, maybe it's not the biggest socialized medicine sector of this country, but it is a socialized medicine sector that a lot of people who are veterans take advantage of when they're after they get out, and then also when they're in the service. They don't have to do co-pays or pay premiums. I mean, they're covered. So the thing is that there are certain sectors of the government that and Congress. I mean, there are certain sectors of the government that are working under a single payer system just fine. It's just the rest of us who are stuck having to fight our insurance company to pay for my skinned knee or for to pay $3,000 for a rabies series that I never even touched that skunk.
Dog bite.
That's right. Yeah, if you have a dog bite or what. No, but the thing is the prices that they're charging are really high, and so and if it comes out of your copay or your deductible, then some of these expenses are just astronomical. I mean, at $8,000, $9,000, $10,000 expense for a regular family is just catastrophic. Although the hospital for a hospital, it's I'm not saying it's chump change, but
it is.
Yeah. I mean, the thing is that we got to negotiate that down with the doctor down to $4,000. Well, how was that negotiation?
But some of the best insurance policies currently have a $6,000 deductible.
Yeah, we have one of those.
Yeah.
and they're not that great.
But that's what some of the better ones.
Yeah, $6,000 per individual and like $9,000 for the family or something like that.
Yeah, right. Yeah. I actually wanted to comment on one other thing. The press, both the TV and printed news, frequently, tends to discount single payer because they say that it's going to cost in the neighborhood of $400 billion, and there's no way to support that expense. The fact is that that's probably a pretty good estimate of what the total cost might be. However, when they quote that, they don't tell you that there's an instant savings. That actually the cost, out-of-pocket cost for single payer would be around $331 billion.
So you're talking about the California.
If you did in California, yes, absolutely. And that's a difference of almost $70 billion. And
that's real money.
Well, and because California puts a lot of money into the federal system, if we got that money back for ourselves, that would offset a huge amount of
well, that's kind of the $331 billion assumes we're going to get all of our money back. That includes the amount that the state pays, the federal government pays, and actually the $70 billion difference is pretty much what the individual pays.
Now, I'm sure getting that money back would require us getting permission from the federal government to allow that to happen.
And the naysayers throw that one up all the time.
Well, the thing is that's why our every vote counts. It's important for everybody to make this one of their most important issues, if not the most important issue, because everybody needs health care at some point in their life. And this will impact your children, your brother, your sister, your parents. It will impact everybody. And so it is so important for us to get this system right finally, because right now we are just throwing money away. And we have to stop that as soon as possible. When Obama said, if we started from scratch, we would have done a single payer system. Well, it's at the point where we have to start from scratch because what is existing now is so broken. It is so wrong. I mean, wait until open enrollment happens this next year. In December, just take a look at what the premium increases are going to be, given what the undermining of this system that Trump has been doing. I mean, they're getting rid of they got rid of the individual mandate. They're cobbling out these very low service association plans that
really don't
young
cover
people
anything.
They don't cover anything. But the thing is, the person who's 20 or 30 years old says, "Oh, I'll take that one because it's only $10 a month," and that means essentially what you end up having is lemon socialism. You end up having all the ones who are going to need real insurance are going to be put into the basket of not paying for those substandard.
Yeah,
plans.
actually, many of those policies do not qualify to get you to the subsidy.
Right. Yeah. Right. So
Yeah,
that means
you can't get subsidy. You
Right.
cannot get the subsidy when you're buying that level of quote insurance.
Yeah, because it's not a standard. It's not a normal standard of care.
And those were that's how Obama got in trouble. Those were illegal under Obamacare, and everybody complained about that. They said we could have the same insurance that we had before. And he said, well, yes, but you can't have crap.
Well,
You know?
I mean, I don't know how he was able to say that. Because you can only buy what the insurance companies, offer.
Well,
and he wasn't guaranteeing they were going to offer the same policy the next year.
No, but he would provide the floor, and I guess he assumed that floor was what everybody was going to be offering.
Yeah.
Oh, I think he was saying something that he knew would be palatable to voters.
Right.
But
Right.
you
Well,
know.
because the thing is that by saying that you can keep what you already have, that makes it so simple. People don't even have to think. Whereas, and the thing is that a lot of times what politicians will do is they'll try to sell you something in less than 15 seconds. Because the thing is that's about the attention span of a lot of people, unfortunately.
Yeah. Well, and the biggest roadblock to making a big change like going to single payer is that, I forget what they call it, loss aversion, I think. People are afraid of losing what they have. And that's an argument you hear all the time. Well, there are all these millions of people who have employer-provided health care, and they actually like it. Well, you know what? More and more of them are not liking it.
That's right. It's just like you're clinging onto a sinking ship. The thing is that, well, at least it's above water this month, and next month you're going to have to say, well, I guess we're going to have to, not cover the kids. I guess next month we're not going to have to cover the spouse, and at some point, I can't, I just need a catastrophic so that if I have a heart attack, they don't take my house. And essentially that's where it's coming to, is that the extraction of money from people for this false insurance is reaching a breaking point where people cannot afford it anymore. I mean, the people used to think, oh, what a nice convenience, back after World War II. What a nice convenience to have this added on as a additional benefit to, for health insurance. Now it's 18% of our economy. And it is just like it's almost as bad as the military-industrial complex in terms of how rapacious it is in sucking money out of people's pockets.
Well, and how much fear people live under.
A lot of people only work for their benefits. They don't work for money anymore. Yeah. I mean, there's one person who works for the benefits and one person who works for income. And the person who's working for benefits, at some point, the benefits aren't going to be enough.
Well, those are lucky families that have, two people who can split that burden. There are plenty of families that have, nobody who's working for benefits. And so
they have no benefits.
Or the person who's working for the benefits gets sick.
Yeah. Yeah.
And then they
lose
can't
their
work
job.
and they lose the benefits.
But hey, you have COBRA. So if you can afford the premium, you can keep your insurance for the next 18 months, and then in California you can extend your COBRA for another 12 months. The thing is COBRA
premiums are huge.
No, well, they're the premium the employer pays. So the thing is
they're more.
No, I think they're more.
In our place,
certainly more than a lot of people can afford.
At our place,
especially when they're laid off.
At our place where we work, it's like you actually get billed. Blue Shield, you get your Blue Shield bill, and then down below you have your COBRA people, and they're the same rates, except for us they're age rated. So if you're 60, you pay double of what the person who's age 30 gets paid. It has to pay. But the thing is that, and then they add on like an additional I think 2% administrative charge or something for the, and then there's a third party administrator for the COBRA thing, because to make certain that you don't screw up on the COBRA, because if you don't offer COBRA, and when you're supposed to offer COBRA and you don't keep on top of it and make certain that they're paying their premiums, sometimes they pay you and then you pay your
layers of bureaucracy.
It's just, and this is the employer who only wants to do, make their widget. They never got into the health insurance business. They never thought about, whether or not they were going to have to say, well, how many kids do you have? And, hopefully you don't have a pre-existing condition, because that'll bump you up. And maybe not anymore, but it will.
Well, it looks like it's coming.
Yeah. So anyway,
in terms of that 60-year-old who pays twice what the 30-year-old, that's a lot.
Yeah, tell me about it. I'm the 60-year-old. Anyway, and I see the premiums, and I see it coming down the road, because we can talk about this now. We're going to be coming back in a couple of weeks, because the day after that's July 31st, isn't it? August 1st? Is that
July 31st is Medicare's birthday.
There you go.
Yay!
So we're going to talk about that next time.
And
actually, an announcement I wanted to make is our local single payer group is going to be looking at developing a chapter for the Physicians National Health Program.
Wonderful.
PNHP. And we're having an organizing meeting a week from tonight.
Oh, wonderful.
7 p.m.
Where?
1520 North San Joaquin.
Oh, that's where it was last time.
Yeah, could be.
Yeah, 1520 North San Joaquin. Okay.
7 p.m. You can give me a call.
Wonderful.
209-467-0522.
Okay.
Yeah. We had to get 5 local doctors, and we did. And we have a few non-doctors as well.
Actually, and we're looking for students.
And we are looking for students
medical
now.
students or
pharmacy
students in pharmacy. Yes.
Yeah. Allied health.
And they can join for free.
That's great.
Yeah.
Because the thing is that I do believe when people start hearing about, they already know what a mess our existing system is, but if they can see that there is a reasonable, rational option that the rest of the world embraces, they'll rush to it. They just have to believe that, like you're saying, the loss aversion has got to be overcome. That people have to say, okay, this is going to be better than what I have. It's not just going to be as good, it's going to be better.
And when you hear that $400,000 quote, know that the actual
$400 billion.
$400 billion quote, that the actual out of pocket is in the $300 billion. $331 is the quote that we're given.
Looking to a national program, though, I'm so hopeful. I'm so heartened by the election of Alexandria Ocasio-Cortez, because that was her number one plank in her platform, and that's the number one plank in all the progressive Democrats' platforms who are running.
And it doesn't have to be Democrats. I mean, Republicans can embrace the single payer or Medicare for all system as well. It doesn't have to be political. The thing is that, and it just happens that the progressive Democrats are the ones in Bernie's group are the folks who are picking up the mantle here. But at some point, everybody is going to be saying, yeah, of course. Why not? 20 years from now. I mean, it is the logical, it's inevitable. Sooner or later, we're going to come to that system, because we cannot afford this. We can't afford double-digit increases forever.
Well, there's a huge contingent of the business community that sees that, and they want to get out of the healthcare business, and they also see what the healthcare provider, the insurance companies who sell healthcare coverage, the profits that they're making off of businesses.
Right.
So when you get the rest of the business community, turning against the healthcare insurance industry, maybe we'll see some action.
Very good. Well, this has been Peace and Justice Connections, where we've been talking about single payer and Medicare for all healthcare system that we're all going to get to sooner or later. Kathy Mathis, Max Heinemann, thanks so much for your time, and good evening.
Thanks for having us.
Mm-hmm. one last announcement. We really want to make certain that you come to the Medicare birthday party.
Absolutely.
And that's going to be July 31st. That's a Tuesday.
Yes.
Tuesday evening.
Tuesday evening.
And whereabouts is that?
Whirlow's. On
Whirlow's.
the Miracle Mile.
Oh, how cool.
And we
Across
will
the
be
street from where we are.
Yeah, it's across the street from the Peace and Justice Center.
And what time is that?
It's around 5:36.
Okay.
We're gonna have finger foods,
Free
complimentary,
Cool.
and you're welcome to buy yourself dinner. Whirlow's would appreciate it.
Sure.
And the usual patronage at Whirlow's will be there with the band that's playing that night,
Cool.
and we're gonna have ask them to play a few special songs for us.
Very
and
nice.
we'll be speaking.
Like Happy Birthday.
Yeah, we have some, some Medicare songs. Yeah.
Medicare songs.
There's one that's been rewritten to the tune of When I'm 64. We're hoping the band
Oh,
can
wonderful.
play. Yeah.
Very good. Well, okay, great. And that is on July 31st, about 5:30, Whirlow's on the Miracle Mile across from Peace and Justice Center.
Yeah, come celebrate.
Thank you.